Thank you. Thank you, Professor Orong and Chairman, ladies and gentlemen. As you know, Anthony has already fulfilled half of my talk, so I can almost go home from here onwards. But this topic about how to deal with branches from the false lumen. Well, depending on the situation, because a lot of the time there are no true false lumen branches except very rare occasions that the penetrating branches are occluded. So in the situation, most likely we need to treat something is due to malperfusion. And in chronic situation, most of the time we don't need to deal with the loss of the false lumen branches, apart from as a part of the treatment for dissecting aneurysm. There's no level 1 evidence what we should do, outside acute malperfusion. A study back in 2016 looked at all the branches from after TIVA over 5 years in the California group. You only need to intervene less than 2.6% of the visceral branches. So this situation are few and far between. And our objective is, of course, is to achieve perfusion in the end organ and to prevent backflow back into our dissection when we do our repair. I'm not going to talk much about malperfusion because the incidence is high. In the type A situation, acute cardiac surgery will take care of most of it. But on the type B, most of these are more subtle. As you see, in the IRAC data and also the Massachusetts data, the branch vessel problem, account for probably half. But when they actually collate to becomes mesenteric infarct or renal failure, probably less than 10%. And there are two types of branch obstruction, the dynamic one, which most of us have to deal with, and very rarely in the static one. And we can detect all these things through radiology guidance from CT, biochemistry, and clinically from the patient. I'm going to share with you a few cases that I have done in the past to illustrate what we do with the false lumen branches. The first gentleman is a type B dissection that I seen back in 2015 with a contained rupture. As you can see, the SMA and also the left renal was involved. But he had no symptom of ischemic gut, and all I did was to put standard TIVA in. And during a 4-year follow-up, which I saw him recently, the renal and the SMA were completely fine. There's nothing seriously need to be done. The creatinine was fine, and I monitored with the ultrasound. And it goes to illustrate how often that we need to deal with the false lumen branches. The second case, which is I've done actually a few days prior to coming here, was a elective cases which I treat as part of a dissecting aneurysm. The patient was treated first by me when I first came to Singapore, 3 months landed in Singapore, and he had acute type B dissection, and I treated with TIVA and left carotid subclavian bypass. Over this time, he had one false lumen branches, as you can see, from the right renal, and I've been monitoring him. He has no renal function, but his aneurysm grew recently to 6.2 centimeter, and he had a single renal feeding from the false lumen and very little partially from the true lumen. So I ordered a CMD repair, and just prior, it may not show very well on the angiogram, but just prior to I do the repair, I did an on-table angiogram. The haziness on the left side of the slide is actually the false lumen of the aorta. And you can just about see the left renal. The right renal is not visible at all, and the SMA is very visible. So I put the standard device in, and much to my surprise, the right renal was very easy to cannulate, and we managed to cannulate through the true and the false lumen of the aorta into the renal intima, and we managed to deploy the stent. We used a very long atrium as the diameter of the false lumen of the aorta was quite big, and it was successfully deployed with no problem. You can see the renal artery is well perfused on the right side. And the patient ended up having a metal jacket and was discharged yesterday from my hospital. The third case I do, you see not all of these I deal with is in an endovascular setting. Recently, the first case I want to show you is in October 2018. The patient had a type A dissection with a standard heavy arch repair. The patient had a very complex dissection and the remaining type B. However, at 2.5 months